Well, good evening, everybody. It's kind of showtime. It's summertime in Chicago, and I got a ton of stuff I'd love to share with all of you. We'll handle questions later. So I have to say, demystifying cementation and really of indirect restorations. Well, what are we going to really be talking about? Let's talk about it. Can life really be as easy as you insert a crown, you tack cure, you just peel it away, it's got calcium release, it's got a self-adhesive chemistry, and you say goodbye to the patient? Well, let's just take a look. Minimal retention on a tooth, minimal, small tooth, like you all don't have these. I pre-check the occlusion before I insert. I want to make sure I've got canine guidance. And I'm going to go through all the steps. I just want to show you how easy this is. So we're going to go through cleansing the tooth, cleansing the crown, everything else. But this is the insertion, finger pressure, 2-second tack curing, and peeling away. And if you can peel away cement and lose that stress of leaving resin cement in the sulcus, that's the key. And you see no bleeding, because this can be done atraumatically. And you don't want bleeding because that can create instant micro leakage. We'll get more into it, but I just want to show you how simple this process can possibly be. Let's take a look at zirconia and the trends today. So zirconia is really one of the all ceramics out there, and metal's just going bye-bye. I'm going to show you a metal case tonight because metal cannot be all gone. But again, I'm just saying it's really turning into a world of Emax, dilithium, and zirconia is growing even at a faster pace than anything else. When I look at Glidewell statistics, you can see third from the left, the Bruxer crown, and again, this isn't a Bruxer course, the growth. Just look at the growth rate in this. It's almost as big as implants, and that's just their Bruxer crowns. So we are in the world of zirconia. There is no doubt about it. We're in the world of zirconia. And what I really want you to understand is it contains no glass. So when they look at SEMs of other materials, this is an extremely densely sintered ceramic. And because it is not treated as a dilithium or other ceramics. And everybody out there has to understand that. And cementation is different, and thus tonight's webinar. So let's start into understanding the steps to zirconia cementation. Well, the first thing is how do you clean it? And it's amazing when I'm on the road teaching how this is really all done poorly. So if you're not cleaning the tooth right and you're not cleaning the zirconia right, then honestly, it's setting up for failure. So what is the literature, what does their literature say? So zirconia itself has a strong affinity to phosphate groups, which are found in saliva. So if it has a strong affinity, here's what happens. This is through the studies. You try in your crown and you have saliva contaminate the inside of the crown. And an XPS analysis shows that you have this organic coating that basically resists complete removal with water, alcohol, or phosphoric acid. And most dentists think, I'll just rinse it with water or alcohol and it's clean. Studies show it's absolutely, positively not. And the worst thing you can do with zirconia is phosphoric etch it. It's the worst thing. So saliva contamination adversely affects resin bonding to zirconia because it deposits that organic adhesive coating in the first few seconds of exposure. So people say, you know, I'll just do it quickly and wash it off. Study after study says no. So you have to also understand zirconia is as a ceramic has no glass. It is acid resistant and is resistant to acid etching. And it's been shown not to produce significant topographic alteration internally. So acid etching is not what you want to be doing. So let's talk sandblasting. Sandblasting's okay. Sandblasting with 50 micron aluminum particles, like, do you really know how big your particles or small they are? Just asking. They produce higher shear bond strengths. Why? what you're really doing is you're increasing the surface roughness. That's really what you're doing internally. And it's been shown, though, that sandblasting can create micro cracks. Now, you never sandblast Emax, never. We all know that. But sandblasting could create micro cracks in zirconia and potentially decrease strength. So then what do we do? So the studies came out really almost 10 years ago, and this was in Journal of Prosthetic Dentistry. Selective infiltration etching technique was introduced to improve resin cement bonding to ceramics. In this technique, a specific glass infiltration, and this was IvoClean, was utilized to be capable of really creating that nano intergrain porosity that you want for cementation. After rinsing off this agent, the study said the surface of zirconia can be then creating this nanomechanical bond with an adhesive resin. So understand this. The studies went back and compared then IvoClean to water, alcohol, and phosphoric acid, and it totally shined. So the first step, no matter what, after you've adjusted your crown, contacts, occlusion, and I never grind on the inside of a zirconia crown, never. If it doesn't fit, you reimpress, and they should be fitting. So the first step is cleaning. So there are two products on the market. IvoClean by Ivoclar, which I've been using for years. Just shake it, apply for 20 seconds. Zirclean, the latest product from Bisco, works in a similar way for cleaning zirconia. And again, I will just tell you, I think both of these products are excellent. IvoClean is an alkaline suspension, and it's made up of zirconium oxide particles. And it was specifically developed to remove the contamination from zirconia as it does from Emax. And really what it's really all about is the small particle size. And the small particle size can remove the phosphate contaminants internally. IvoClean will absorb those contaminants, and basically after 20 seconds, you rinse them off. Zirclean, the steps are as simple. It's a 20-second, and I like to scrub and make sure all the surfaces come in contact with Zirclean. And you can put it in a dabbing dish and brush it. In fact, we use the Viscostat brushes. We absolutely love the brushes. They go directly on this. We just scrub the crown for 20 seconds and rinse, and we use an air-only dry. So air-only syringe, and we dry the crown. Both are great materials, both. Ivoclar has great studies with IvoClean cleaning their surfaces, and this is a Bisco study. And it shows in red that when you try in a restoration, the initial strength is, let's say, 32 megapascals. With Zirclean, you actually increase the strength, in other words, the adhesiveness or the retention to the nanocrystal microstructure. But with water, look how much weaker it is. And with phosphoric acid, it's much, much weaker than the original strength. So this is why water, alcohol, and phosphoric acid are out. It's really IvoClean or Zirclean. And with the testing with Bisco cements, you can see that with no contamination and no cleaning, you can kind of see the shear bond strength. Well, once you have saliva contamination with Theracem in the yellow on the left, you can see Theracem as a cement has low retention if it's on contaminated surface. Once it was cleaned in blue, you can see the retention skyrockets. The key is that if you want these to stick, you must clean them properly. So I'll start with some Theracem cases, then I'll show you Z Prime and Duolink. And it's interesting because if you look, Z Prime, which is a zirconia primer, and this is one of the questions I ask on the quiz later, Z Prime is not indicated in every cement for zirconia. With Theracem, you do not need to prime the inside of the crown. You clean it with Zirclean or IvoClean, rinse and dry, and then you cement. With Duolink, because it doesn't have MDP, it needs to have a primer internally. So you must know your cements and what they recommend. So the bond strength and interface quality achieved using selective infiltration could be further improved with zirconia primers or silane couplers. So now the question is, what do you use? And so the studies have really shown that for many of these cements, not all, you need to prime or silanate. So when you're priming zirconia, you can use like an Ivoclar Monobond Plus. You can use a Z prime and other primers for zirconia. And again, it all depends on what you're doing. So in the Bisco family, they have a silane product A and B where you mix 2 drops each, and that's what I would be using to silanate Emax or a dilithium product. But for zirconia, if you need it for zirconia, and let's say you're using a different cement and it says you need to prime it, then I would be using Z prime. Ivoclar's Monobond Plus can prime zirconia and prime Emax and dilithiums. So once you cleanse and know whether to prime, now the question is, what do we really want in our dental cements? And I have to tell you, it's really quite interesting. So how do you determine what to use? So you can look at the materials, and now I look at the subgingival margins. Are you subgingival? Can you isolate against gingival crevicular fluid? Does that matter? Well, you don't do bonding in moisture, so why would you cement in moisture, especially like a resin cement? Saliva management. Can you actually manage the saliva? Can you get to it? Is it easy to get to clean? And the retention, does it require adhesion? Does it require an adhesive bond to it because it's a short crown like many of us have? So these are all the things I actually look at, and I'll even get into a little bit more detail. Retention. If I have average to good retention, my product for the last 5 years has been Ceramer. It's a calcium releasing. I'm going to talk more about it. Calibra Bio is really Ceramer. These are 2 wonderful products, and Calibra Bio has been just launched by Dentsply. Fuji Sem2 GC's resin ionomer, it has been the classic, and it just has gotten better and better. Those are my 3 choices because I want some bio interactivity or interactivity. But what if you have less than ideal retention? That's when Theracem has become my gold, so to speak, because a lot of my preps are not ideal, so I really need more retention. And if I need even more retention, because like this morning I prepped number 15, I know I'm going to have to adhesively bond it in because it's so short. That's when you can go to Cavo Kerr's Maxima Elite Chroma, Voco's Bisfix, Dentsply's Calibra Ceram, or Bisco's Duolink, because those are either additional self-adhesives or really, you really have to almost etch or self-etch and bond. And so to me, those are really the next step up, especially the last 3. Isolation is really an issue. If I'm really way subgingival Ceramer or Calibra Bioactive with good retention, subgingival, I don't want any resin. But if isolation is an issue and I don't have retention, then I've got to use something with calcium release or a resin or a fluoride release. And that's where the Theracem is my leader. And then you have Activa Cement, Fuji Sem2, and Rely Exluting. This is the craziness of what we're all trying to do, how to narrow down these cements. So the ideal cement, I want retention. I want a great seal. I want it to resist micro leakage and demineralization. And I'm going to tell you, one of the biggest problems with resin cements is they do shrink. And for many dentists, if they're not careful, they're going to have instant micro leakage. Like what happens when you deliver a self-adhesive, you tack cure, it hasn't fully set yet or close to it, it hasn't set, and you pass floss through there and it starts bleeding. That blood just comes right under the margin and it's instant micro leakage. I call it ring around the collar. And instant demineralization is going to occur. So you've got to look, can I really clean this in an isolated area? Will this cement inhibit caries and plaque? Does it have low solubility? Is it radiopaque? Is it easy to apply because it's thin and easy to clean? Is it biocompatible? Is it comfortable to the patient? All of these are questions that I really just look at when I cement. So I know Bisco's sponsoring tonight, but this is not a commercial for one cement. There is no one answer. And so for years, as I said, I've been using Ceramer. Dentsply just lost Calibra Bio to add to their resin cements. There's no resin. It is literally a calcium aluminate cement. And Theracem is a calcium releasing cement with resin. And so Theracem is different than the previous two. So 5 years ago, we evaluated from Doxa, a small company, Ceramer. And the reason I start off with Ceramer, this has really been one of the most revolutionary changes in dentistry because it's a calcium releasing cement. So for the past 5 years, this has been my go-to cement for crowns and all my implants when I have to cement an implant. And I'm going to be doing a course in September on implants, all the variety of ways we deliver them. And there's more on Ceramer in that because it is a biocompatible cement, just like Calibra Bio. So when would I use Ceramer? Traditional zirconia restorations, well-prepared Emax restorations that were not highly translucent. I would use it for gold restorations, implant restorations, preparations with subgingival margins, preparations that required good to excellent retention. That's when I would use it. And I would only use it if the preparations were not fully composite cores. If they're fully composite cores, then I'm going to use a resin cement to resin bond, obviously, to the core buildup. So this is kind of how I was using Ceramer for the last 5 years, and will continue. And why? And why is Bisco moving into this calcium area? Why is Dentsply? Because what we're trying to do is trying to create almost reactive tooth. Reactive is the key here. So this was in JERD, Journal, and we'll go back, Journal of Aesthetic and Restorative Dentistry, peer-reviewed, done by Stephen Jeffries. Stephen reviewed Ceramer along with many other cements, and his preliminary findings were that you could suggest the capability of surface appetite forming calcium-based bioactive dental cements being able to reseal a marginal gap. Now think about this. This is the holy gospel at this point. Let's take a closer look. So they evaluated a self-adhesive resin cement, and at 31 days it still had an open margin. A resin-modified glass ionomer still had an open margin. Glass ionomer with an open margin. And then it was a calcium alumina, which was Ceramer, and a calcium silicate, which was actually MTA. And here's what's crazy. If you look here, you can actually see, let me go back, open, closed, open, closed. And why is that significant? That is so significant because there is no way everybody's putting in sealed margins. You all know it. And you all know that the cement is trying to seal that margin. And here's a study that's suggesting that potentially with calcium ions release, integrating with the saliva, you could remineralize at the margin. This is why calcium is becoming so critical in what we're doing. So the continuing trend is to bioreactive cements. Now, what they call it bioactivity, well, in my eyes, it's bioactivity when you really can reseal margins. But if we can start to go in this direction, amazing. So what we're adding now is a self-adhesive resin with calcium silicate. So Theracem is a self-adhesive fluoride and calcium releasing luting cement. You don't etch the tooth, you don't prime, you don't even have to prime the surfaces for zirconia because of its chemistry. So here's what most people don't know. So the filler particles within the resin are calcium silicate. It's the calcium silicate with a trace of sodium fluoride. So as water saliva diffuses into the Theracem cement, small amounts of sodium fluoride are dissolved. And this is when the fluoride ion is released, and it's a small amount. And the diffused water also starts to set with the calcium silicate, and what forms is a calcium hydroxide byproduct. And what happens then is you get a calcium ion, which can interact with the saliva and potentially make new appetite. And you have a hydroxyl ion, which is alkaline. And anything bioreactive has to be alkaline in nature. So if you have acid attacks, the studies have shown, and I'll get to it, where you actually will have more calcium release because of the hydroxyl ion and the interchange of the calcium silicate. If this can promote appetite formation, which the studies are showing, and inhibit bacterial growth and neutralize acidic byproducts, this is why these cements, in particular Theracem to me, is particularly interesting in comparison to all just traditional self-adhesive resin cements. So this has MDP monomer in it, and this allows bonding to metals and zirconia. So you do not need to prime zirconia. Yes, you need to cyanate Emax or dilithium, but you do not need to prime zirconia because it is a metal. So where do all these numbers fit in? It does have greater calcium release than fluoride release, but understand Ceramer and Calibra Bio, which are not resin cements, have far greater calcium release. But again, Theracem will have greater adhesion. So you have to know what to pick based on retention, isolation, where your margins are. It's got great bond strength to zirconia. In comparison to the others, you can see it's right there. And to other restorations, whether it's lithium disilicate, metal, or zirconia. So I'm going to show you cases of all. So then one of the fun things I get to do is I actually get to ask questions to the researchers. So a lot of you ask questions. So I asked Bisco's researcher, Leon, do resin cements diffuse materials out? And he says they actually do diffuse materials out. Is the amount of sodium fluoride important? He said it actually can be important. Does the diffusion weaken the resin? And he said no. How long does the calcium release go on for? Was it indefinitely? And the answer is indefinitely. It just decreases over time. The studies. One of the studies they sent me showed that during an 80-day study showed that during acid attacks, Theracem increased its calcium release levels. So this is what we're looking for versus a resin that really doesn't diffuse anything. And is this the future of where we're going? So with that as a backdrop, let's do clinical. This is the fractured Emax crown that comes into my practice. You can kind of see it fitting. I just wanted to put it back on the tooth. This was after it had fractured. You can see it's kind of thin in the incisal occlusal area. And why did it fracture? Was it a preparation issue? And I absolutely will tell you it was. It was resin cemented. I can tell you that. So I don't think it was the cement. And the crown was only 4 years old. And so what happens? It was no more than 1 millimeter thick. Patient's full mouth rehab. And this was the most recent crown she had done in recent years. So here's the challenge. It's a short height. Now I'm an Itero guy. I love digital scanning. I know there are other great digital scanners out there, so I will absolutely not trash any of them. I'm just an Itero guy. I love what it does for me, and it's so easy. My staff, my team uses it. We use it on all initial exams. It's just a great, great tool. So here's the scan. And you can see the opposing is PFMs. It's a short height. I don't have a large interocclusal space. I did not have the option of adjusting the opposing occlusion. So my only option here is not Emax because I only had 1 millimeter of clearance. So I can use an aesthetic zirconia here because I'm in a low, what I call Newton force range. There's so much more occlusal pressure on the molars than a bicuspid. So a millimeter thickness in a bicuspid allows me to be comfortable using today's aesthetic zirconias. So I call this digital scanning in today's modern materials. So let me just say, I am not Joe Fancy, I'm just Lou. This is a $99 monolithic, and I'm going to show you the maker of it from my local wonderful lab. 99 bucks. And it's out there. He never sends me a model on my monolithic stuff. It just comes wrapped in a cutesy little clear container. And so what type of zirconia are you asking for? How do you choose which zirconia you're asking for? So here's the Itero. So, I mean, I have to tell you, digital scanning shows you so much more. And it's not just the impression. There's just so much more to these digital systems. So now I can rotate it and you can actually see the clearance. I can communicate this obviously with the lab. And now when it comes back, this is well, we'll get more into the zirconia when I'm done. I notice the crown's a little tight. I use articulating paper in between the teeth. And then what I'll do is I'll put the crown in, remove the crown, and you will see that it's a little bit heavy in certain little spots. I'll spot adjust it. And when I'm done, I'll polish it with zirconia polishers. Once the contact is done, then I look at the occlusion. So after verifying the contacts and margins, that's when I would take an x-ray. The occlusion is then evaluated, and I only adjust the occlusion once I know I'm fully seated. Once I'm fully done, then I will do all my finishing and polishing with zirconia polishers, always with water. So what's the process? I'm going to take Zirclean for 20 seconds, and all I'm going to do is scrub it for 20 seconds, rinse it, and air dry. Now, let's say I'm working on a tooth and the temporary had some bleeding. One of my favorite products is Traxident from Premier. Love this product. It comes in a system where you have these comfort caps that are seen below. They're scalloped. So if you have some bleeding, you cannot cement in blood. Don't look up and see if somebody's watching. You know you can't cement in blood. So if there's bleeding, I'll inject a little bit in the area. I have the patient bite down on one of the comfort caps for 2 minutes, and then I rinse. Just rinse it away. Now, one of the questions was, if you're using an aluminum chloride like Traxident, do you get decreased bond strengths? The answer is yes. That's what the studies show. Studies go back 5 and 6 years. So I'm going to clean the preparation, oftentimes with a 2% chlorhexidine, which is Cavity Cleanser by Bisco, or you can use a Conceptus Scrub by Ultradent. Ultradent makes all these nifty little instruments to scrub a tooth and clean a tooth, so you can actually clean the tooth with some Conceptus Scrub, and you're just trying to remove the smear layer. Then you rinse off that area and lightly dry. So what would I use in this case? Based on the preparation and not a great amount of retention, Ceramer and RMGIs were not my primary option. Traditional resin cements are an option, but I had subgingival margins. So I went to Theracem. So all I do with Theracem is, after my assistant loads it, finger pressure. I want to make sure the cement extrudes 360 degrees. So my assistant loads it. I want to make sure I see the extrusion. I hold it down for about 5 to 10 seconds, maybe 15, and then I have the patient bite down. I want to make sure my occlusion is right. And then what I'm going to do is I'm going to tack cure. So I'm a Velo light guy, love the light. I'll use it on its lowest setting. You can set it on a tack cure setting at their 1400, and it's a 1 second tack cure. But the beauty of Theracem is in the lower right screen. What happens is as soon as you tack cure it, you just peel it. So I'll tack cure the buccal, peel. Go to the lingual, tack cure, peel. And then what I will do is, after I have tack cured the buccal and lingual and peeled, I'll tack cure again 1 second interproximally. And then all I'm going to do is take an Explorer, flick out the cement, and take my floss and pass it through down, just go down through the contact on the lower, or up through the contact on the top on a maxillary tooth, and then slightly pull it out. You can create a little knot and pull it through. So once I get the primary cement out, all I'm going to then do is tack cure again around the margins, and I'll go in and remove any additional cement. It just peels away. So I've already removed the initial cement. You can see some floating on her tongue or underneath her tongue. And so all I'm going to then do is pass the floss down and pull it out. Notice there is no bleeding. I don't want micro leakage. After the 4-minute mark, you re-cure buccally and lingually. And if you need to do any final occlusal adjustments, because all of a sudden the patient says, oh my God, it feels a little high, like that never happens. Yeah, sure. You wait to the 4-minute mark when it is set fully internally. So I'm curing buccolingual. And this is from the occlusal view. And this is the Zolid FX multi-layer zirconia. So it has a definite lower value. Kind of reminds me of Emax of a lower value. And it is absolutely gorgeous. I mean, compared to PFMs that are in her mouth. The maker is Amann Gerbach. And I believe it's an German or Austrian company. And these multi-layers are polychromatic. They're super high translucent. So if you don't want super high translucent, you better tell the lab. You see like a smooth shade transition. You don't see like all of a sudden it's A3 and then A2 is like a vertical or horizontal line. Their strength is about, I'll say 2/3 of normal zirconia. And I'll show you a case when we're done today of an online. They're just great for that. When I look at Bruxers and how does it fit in here, Bruxer anteriors are like Zolid FX multi-layer. A Bruxer zirconia is a much prettier crown than honestly the original Bruxer. So you can see that you've got 720 megapascals of strength on the Bruxer anterior, just like the Zolid multi-layer FX, but the Zolid HT is like a Bruxer zirconia, which is really way up on the megapascals of strength. So when would I use a Zolid or a Bruxer? Is when I got a millimeter or 8/10 or 9/10 of a millimeter on a second molar. I'm not using a multi-layer aesthetic zirconia because it's not strong enough on a second molar unless you've got additional room, like 1.5 millimeters. And who has that on a second molar? Nobody. So what if the opposing was not ceramic? In your treatment planning, you must tell the lab. Tell the lab, what do you want them to do? Do you want them to glaze it because it's opposing zirconia, Emax, or porcelain? Or do you want the lab to mechanically polish it? Notice the difference. Glazed zirconia has much more wear on enamel or natural tooth than if you polish it manually or the lab. So you have to ask the lab, tell the lab, opposes natural tooth, please mechanically polish the occlusal surface. And so then we get into treatment planning for long-term success. So let's talk. James is 82 years old. He just moved from Houston, and he has tooth number 32, and he's lost a 1-year-old ceramic crown. So he's 82, paid $1,400 for this in Houston, and he's not happy. He has no symptoms. The tooth is limited height, has limited occlusal clearance and minimum retention. Gee, I love those preps. And what happens? The zirconia crown was 3/10 of a millimeter thick. 3/10. I don't even know why a lab would make this. It's just going to break 1 year out. So what did I do? I cleaned it up. I put in some vertical retention grooves, double packed the cord, and I scanned. That's my scan picture. Here's the occlusion. This is after the scanning. And as you can see, I'm still limited. I could adjust the opposing, and what I would do is if I adjust the opposing, you just rescan the opposing. It takes less than 30 seconds. Or I could adjust tooth number 32 and use the eraser tool. So what you do is, Itero has an eraser tool. You just erase the occlusal surface. You don't have to repack cord. You re-prep the tooth, and you rescan. It's great. But the problem was I didn't want to really reduce number 32. It was already too short. So I made it temporary, prayed it would last a week or week and a half because it's thin. And I told the lab I would adjust the opposing. Today, like today's patient, what do? What I do is I do a pre-treatment scan and I want to see where I have to prep extra. So in the old days, I would either make a temporary, and the temporary would tell me where I was thin. But now I can actually just take a pre-scan and see where I have to prep either the preparation or the opposing tooth. Love all this digital. So what is the best long-term solution given his clinical situation? This is how we maximize digital diagnostics. So once I click on the occlusal clearance icon, it's no wonder this restoration failed. If you see, this is the topography in his bite. The orange area is basically at 2/10, the yellow area is 3 to 4/10 of a millimeter thick. You're never going to have zirconia last when it's 3/10 or 4/10 of a millimeter thick. So I've got a short tooth, nowhere to prep. I can't prep another 0.5 millimeter down. I just can't. I'll have no retention. So then you look on the opposing. The opposing's on the right. You can see where the zirconia bridge is hitting. And you can see it on the distolingual area. So you could spot adjust now and rescan, or you can maybe make another decision. So what are your best options at this point? What would you do? So I told the lab I would adjust the opposing, but I was very limited because it was a zirconia bridge and I want to put a hole in that. So what are my material options? Could I use another zirconia, like a really strong zirconia? Yeah, forget it. Why? So here's why. The force needed to fracture zirconia at 0.6 of a millimeter is around 400 newtons. Well, on a second or third molar, you could get 800 newtons. So as you go on this graph and you look at 800 newtons, now slide over to the thickness, you need to be anywhere from 0.8 to 1 millimeter thick on a second molar. 0.8 to 1 millimeter thick. There was no way I was going to get it that thick. No way. So would I adjust the opposing 0.5 millimeter? No way. So I couldn't adjust the opposing, and I knew I had forces greater than 400 newtons. So I ask you, is gold really dead? So that's what we did. Oh, I know this is a zirconia course. So this is gold. Welcome to success. He's 82 years old. I don't think this will affect his social life. So this is what I told him was the best long-term solution. It's $100 extra over zirconia. So the lab has to cast it. So they need to make a model. The model could take a couple days to be fabricated for them. The lab can tell me where to adjust the opposing. What's amazing today is I've seen they can now mill gold crowns. Mill, just like they mill zirconia, they can mill gold, even better retention. Well, this was cast. So now here's the challenge. What are you going to cement with? You got low retention, isolation, everything else are issues. So retention, I needed some kind of adhesive resin. Could I isolate the area? Not really that well. I could keep the saliva out. Will the cement be too runny or keep the margin protected until I tack here? So for example, Ceramer and Calibra Bio are a little bit runnier. So it could run down there and I could lose that. So I don't necessarily want I'll call it a looser cement. I love it when I wanted to seal everything, but I got to control it. This would have been a tough area. And my margins are subgingival. So what did I do? All I did was follow the same thing. You don't need to Z prime that metal because it has MDP in it. I cleansed the tooth, placed TheraSem in, and look, it is not running. It's fixed right around there. We make sure it's fully seated, tack cure, and peel. That's all you have to do. Wait 4 minutes, re-cure all the margins, and have a good day. You can see how we peeled it on the lower right-hand screen. That's how easily this peels, no bleeding. So the compromise in this clinical case was that he didn't want to have a sinus lift. He had a pneumatized sinus. He just wanted to chew on his teeth. So what did we do? After showing him what his issues were, we pre-probed the tissue. We then did a laser gingivectomy. You can see the immediate retention. So when we probed the tissue, we knew we had about 5 millimeters of like literally bone sounding. So I knew I could easily remove 3 millimeters of tissue. So that's what we wanted to do. So I just removed 3 millimeters of tissue, re-prepared the occlusal, and so I could have a millimeter of clearance. I brought him back 2 weeks later, double retraction cord technique. And what's the beauty of digital scanning is you pull one cord at a time, you scan one tooth, save each tooth, and it is just beautiful. You don't have to worry about pulling 8 cords at one time. It's one cord at one time. So it literally, you could scan 5 teeth, but it's one at a time. This is the double cord retraction. This is the image itself, just looking at your margins. If you wanted to adjust a margin, you could erase and repack and re-prepare. Looking at the occlusal room. And approximately, we had 1 millimeter of clearance on tooth number 4 or 5, as I should say, and about a 0.5 millimeter on number 1. That's all I could have. It was a short tooth on the distal lingual area. So what we pick? We picked gold for the molar again, and an aesthetic zirconia for the anterior tooth. So when we cemented, I actually had enough room to cement number 5 with Ceramer and Theracem because I needed more retention with the calcium release and obviously subgingival margins. Now I could have cemented both with Theracem, no doubt, but Ceramer would not have been retentive enough for tooth number 2. Replacing a zirconia bridge. I don't think there's anything, well, maybe an Emax bridge. Cutting these bridges off is just no fun, and this is recurrent decay on number 19 distal. And what I'll tell you is that I couldn't imagine not having an electric handpiece today. The worst thing I ever did was I bought one. I have 9 ops, and there's no way I didn't want to work in any other op except my electric op. So this is the NSK NLZ. I have Cavo Kurz electrics. They're wonderful. I have Dentsply's electrics. They're wonderful. So this was our latest addition, and I'll tell you why. The NLZ has changed their magnets, and their magnets have gone from 2 to 4. And what does that mean? I get about 30% more torque in this NSK NLZ than other electric handpieces. I definitely can feel the torque difference. The others are excellent, but this is how they keep improving. It's amazing how they keep improving. And this model actually has less heat than their existing model, which had less torque. So just letting you know, even electrics to remove a zirconia bridge, so much nicer dealing with those sparks when you can just glide through it than first is just pushing with air. And I'm telling you, when you start removing these, you're just going to have to move away from air driven. Well, here's his Itero full scan. Some miracle mix buildups. His opposing, and on the opposing, we noticed a periolus. He needed endo on number 14. That's the detail you get. Now, what do you see here? Here's his full arch. We have no issues. He's got long teeth, and great interocclusal space. So looking at his occlusal analysis, that was not a problem. And why is that important? It gets into decision making. Because bridges fail, like the previous bridge, at the interdental connector. And we want to make sure that interdental connector has enough height and width. And in this case, I could use a more aesthetic zirconia because I had plenty of height and width. So based on that, I could go more cosmetic. So this was the design, and on my geriatric patients, I leave significantly larger embrasures because I want them to proxy brush. Nobody's going to use a floss threader. And an 80-year-old on a floss threader, who are you kidding? No way. So I definitely like wide open embrasures interproximally. We did glaze his occlusal. Why? It was opposing porcelain teeth. To cement, you just, after everything was adjusted, you can see the interproximal areas. We just placed Zirconia on for 20 seconds, rinsed and air dried. Once the internal surfaces are air dried, we just load the Theracem. Make sure all your margins are covered. And this is what you have options with Theracem. You could simply allow it to self-cure, and about 1 minute, you would begin peeling away the cement. But I don't want to wait a minute. So I tack cure the posterior unit, and then you could remove the cement because you want to make sure that's the area you're trying to control the most because it's near the back of the mouth, more saliva. So you could tack cure, remove the cement, and then proceed to the anterior. Or you just tack cure the posterior and tack cure the anterior and start peeling away, which is also easy with just 2 units. Once you've peeled it away, then you're just going to slide the floss down and out. So what do we do again? I tack cure, I peel, I relight cure in approximately for about 2 to 3 seconds. I'll remove any excess cement that I can, and then I'm flossing down and out. You must let the cement set fully for 4 minutes. But this is the environment you cement in. That's it. You got a little inflammation, you're subgingival. You're going to just put a resin cement in? I don't think so. Just don't think so. I really think you absolutely have to control this. I'm not going to cement, obviously, all this saliva, for sure. This is the most 4 minutes are so critical to a good long-term success. So here's this first recall with this aesthetic zirconia. Great tissue. Notice the interproximal area. Easy to proxy brush and keep clean. That's what I want. Last case. I chipped my tooth. Can I come in? Yeah, I love when this happens. On the left, I had done an MOD composite on him in 2009. He came in 3 weeks ago and he fractured off the entire buccal cusp with the MOD composite. So it was just basically a flat line. And now there was a mesial distal crack. You could see a crack line running across. We took a periapical, there was nothing, and he has no chewing sensitivity. So we tested his tooth, it's live. It's got a mesial distal crack line. What do? Do you extract the tooth? Do you do an intentional root canal, post and core crown? Or how about minimally invasive dentistry? My goal was to save enamel. He still had a lot of enamel. I wanted to create some mechanism to allow consistent placement. So I just built up the buccal cusp so that when I tried on the crown, it wouldn't be a flat top and slide around. I hate flat tops. I don't get that concept because they just slide. So I did a self-adhesive technique where I self-adhese using a universal bond. In this case, it could be all bond or one of the many self-adhesives. No reason to etch there because it's only dentin. And you do a core buildup. And the core buildup is a small buccal cusp. This is all I've got. I have poor retention. So after my buildup, you have decisions. Do I want to drop my margins and take all the enamel away? And I'd still not have an ideal retention. So I said, no, let's just do an onlay. So I scan it, comes back, polychromatic zirconia. You can see on the left, you can see a little bit of that indentation for retention. So I know when I try it in, it's not rocking around. Isolation. So when I deliver this case, I'm not going to use Theracem. I need something more retentive. So I isolate because I want to put my retraction cords in because I want to make sure gingival clavicular fluid is minimized and I'm not going to get any resin stuck below the margin. So what do? I'm going to clean the zirconia, and this is zirconia. I'm going to clean it with Zirclean. After 20 seconds, I'm going to prime it. I prime it for 30 seconds and I air dry. Now it's ready. The tooth, I cleansed it with some Preppies in this case. I'm going to etch the enamel. Are you kidding? You've got enamel. Etch the enamel. So you can do a total etch or a selective etch where you just etch the enamel. Total etch, you etch everything. I'm not really worried about it in this tooth. So I missed a little dentin, big deal. So it was a modified total etch, selective etch. You're going to rinse it and I air dry it nice and lightly. Why? I don't want my resin, my composite core, moist at all. And the beautiful thing about universal bonding agents is that when you put the universal bonding agent on, it can go on a dry tooth or a moist tooth. I'm not worried about collagen in this case. So I'm just going to then scrub this for 20 seconds on the tooth. So all I'm going to do is scrub it for 20 seconds, air dry with air only syringe and light cure from different angles. Yeah, he's got some stained teeth, doesn't care. Cement, it's not a self-adhesive, it's a resin cement, so you must bond it. So we've primed the crown or the onlay, and now we've etched and bonded the tooth. So we load it, you can see the cement there. I'm going to tack cure for 1 or 2 seconds, and it just peels away. And there are a lot of great cements that peel away. So I'm just going to peel it away. Then I'm going to go to the lingual and do the same thing. I'm going to spot tack and peel it away. Minimally invasive, indirect restorative dentistry. And now I'm ready for final polishing. All I've done is peel it away. After 4 minutes, I usually use very fine finishing diamonds at 40,000 RPMs, and then I go with Zirconia polishers. And when I'm done, I've got a beautiful finished lab onlay, all Zirconia, hand polished, ready to go. FYI, let me just go back, canine disclusion, always checking before I start where I want to end up. Let the questions begin, and I hope you all felt this was informative. If you have to run and you want to email me questions, just email me at lou@catapulteducation.com. I've read that sodium hypochlorite is an effective cleansing agent for zirconia. Is that accurate? I've seen no studies on that, Ken, so I can't tell you I'm using sodium hypochlorite on it. I can't say it's wrong or right. I can say the studies have shown with Ivoclean and Zirclean, that's what I'm using. So it says, Susan asked, and I just love an open presentation. Initially, I was performing a full etch prior to cementation. Several crowns cemented with Ceramer came out unseated. What do I have to do to restore the prep to accept the traditional zirconia restoration? Okay, Susan, let me just explain this to you. With Ceramer, which is a great cement, you cannot Z-prime it. Ceramer, all you're going to do is clean it and cement the crown. I want to be clear here. It wants to go on a hydrophilic substance. So the internal side can never be Z-primed. If you Z-prime it, Ceramer will just be an unretentive cement. So Ceramer's in their instructions, they say do not use a primer or a silanator when cementing. Just letting you know. Okay. Next question is, this case was a great one. Thank you for sharing it. How long do you see this restoration lasting? So Claire asked on my last case. Okay, so Claire, that's a great question. So I've resin bonded him. And what we will do is when he comes in, when Paul comes in, we just want to make sure that he has no lateral forces on that upper bicuspid. If he continues in canine disclusion, I feel the adhesive restoration, because I bonded to enamel, will really hold well. And we've seen these last for years. And one of the virtues of being a dentist for 3 decades, you get to see your failures. That's why I did not prep away the enamel. Once you prep away the enamel, your bond strings are just going to go down. So keep the enamel and be more conservative. Okay, next question. If you use monobond, you still need another bonding agent. Okay, Tom, monobond, now I don't use monobond in my practice, but if you're using monobond as a silanator, am I still using a bonding agent on the tooth? It depends on the cement. In the case of Duolink, which is not a self-adhesive, you must use etch if you have enamel, and you must use bonding agent if you've got dentin. And that's just how I look at it. Any thoughts on sandblasting the prep for more retention? Sam, let me just talk about that. As long as you can use a micro etcher on the prep, and I like to use water, I have no problem micro etching a prep. The studies show it is the best way to clean a tooth. Sam, I'm all over that. The problem often with micro etching is if you do it with too much force, you can't go more than 40 PSI. And the reason is all of a sudden the particles hit the tissue and they start to bleed. So Sam, if you're micro etching with PrepSmart or whatever you're doing, I applaud it because it's a wonderful way to go. What other cements do you use that you don't, what other cements do you not need Z-prime? So again, what I will tell you, William, is that you just have to read the instructions. There's so many cements out there. You just have to see, does it need a primer or not? I know Ceramer says no primer. Calibra Bio, no primer. Theracem, no Z prime, no primer at all. How do you treat a prep and tooth if a zirconia or onlay came off before re-cementation? Okay, let me read this one again. How do you treat a prep / tooth if a zirconia onlay has come off before you re-cement it? Well, first off, if you've got resin on it, I mean, are you removing the resin? Are you removing the resin cement? So I must tell you, that's the hardest thing, because if you're going to bond to a resin cement, I just can't see that. So let's assume the cement came off the tooth and you've got resin cement inside the zirconia onlay and you need to get it off. That will be when I'm micro etching the inside of my zirconia, because I've got to get off that cement. I just have to. I'm not going to drill it, because that'll create more microfractures. I will micro etch it. I use Reliex Ultimate. The problem I see with practitioners bonding their crowns is that if recurrent decay occurs, replacing the crown will require a hassle for the practitioner who needs that later. So let me just tell you this. Last week, I had to drill out 4 Emax crowns that were all bonded in place, and they all had recurrent decay and cement overhangs. It took me an hour and a half to literally prep away the Emax crowns. You just have to re-prep like you're prepping a crown. I couldn't agree more. My problem is that, Claire, you have to understand, if you don't have enough retention, like in the last case, in a few cases, you do have to use a resin. What I love about Theracem is the calcium release, and I think you get plenty of retention with it. And I haven't had to remove one Theracem yet, so I can't tell you what they're like to drill off. When I drilled in RMGI or Ceramer, I can certainly tell you they come off a lot easier. There'll be one more question. When you're seating 6 anteriors, do you seat all 6 at once? Do you clean and go? So, Stephen, this is what we're going to do. Our next course is going to be with my partner, Susan, and we're going to do anterior cementation of multiple. So we're going to go through how we seat them, how we remove the cement, and the whole process at our next course. That's our next anterior course. We'll be sending out the email. Thank you all so much. I hope you have a wonderful rest of your summer. Thank you.